Hello all and welcome everyone to this webinar series exploring gross examination frozen sections. This is the fourth and the final webinar in the four-part series. Today's webinar is titled Gross Examination and Frozen Section Webinar Series on Colorectal Carcinoma Specimens. My name is Dr. Kedar Devdar and I am the Royal College of Pathologists International Regional Advisor for Southeast Asia region. I have devised this program with help from Giles Handrati, who is the International Education Officer for the Royal College of Pathologists, with guidance from Professor Martha Cohen, who is the Vice President of Learning for the Royal College of Pathologists. This is the agenda for today. We will have a brief series overview first, then we'll have a lecture by Professor Adrian Bateman on gross examination of colorectal carcinoma specimens. Following that, we'll have a Q&A sessions. And after that, a couple of slides for information for all the attendees. I will encourage all the attendees to write their questions in Q&A session so that as Professor Adrian Bateman is finishing the lectures, we can have a Q&A session. You are welcome to write the questions as lecture progresses. So a little bit about the overview. We planned this as a four-part series, and Wednesday, 5th of February, we had a lecture on gross examination frozen section of head and neck pathology and oncology surgery specimens. In the following Wednesday, we took the lecture on frozen section of breast pathology and oncology surgery specimens. And the last week, on 19th, we had a lecture on gynecological oncology pathology specimens and frozen sections. And today, we plan to have a lecture on colorectal carcinoma specimens, gross examination. The idea of planning this at about this time, because it is probably the convenient time for the Southeast Asia region, but all are welcome. But we also have people joining from Malaysia region, East Africa region, or also some students from UK region. So today we are delighted to welcome Professor Adrian Bateman to take the lecture on colorectal carcinoma specimen. Dr. Adrian Bateman, who has been a consultant histopathologist at Southampton Hospital, UK, which is a major teaching hospital since 1997, and honorary professor at the University of Southampton. His special interests are almost entirely in gastrointestinal and hepatobiliary pancreatic pathology. He is a lead pathologist for the English Bowel Cancer Screening Program, which is also called as BCSP, and the coordinator of the BCSP Pathology Expert Board. He was a lead editor for the most recent or sixth edition of the textbook Gastrointestinal Pathology, Morrison and Dawson's Gastrointestinal Pathology, and he's editor-in-chief of the Journal of Diagnostic Histopathology. He's also the chair of the Royal College of Pathologists Cellular Pathology Specialist Advisory Committee, or SAC. We welcome Professor Adrian Bateman, and over to Dr. Bateman, and he can start the lecture.
Thank you very much, Kedar, for that kind introduction and for inviting me to talk. So I haven't made my presentation too long on purpose because there will then be plenty of time for questions. Afterwards, just for people outside the UK, to point out where Southampton is at the very south of the UK, down here near the Isle of Wight. So our hospital is in the middle of here. It's a major teaching hospital. This is a picture of Southampton. That's where I'm talking to you from today. So I know that colorectal cancer resection specimens, of course, commonly received in many parts of the world. That'll be something that people will often see in their cut-up. I'm sure many people on this call or this webinar will have plenty of experience of dealing with them. But I hope that I can still provide some useful tips for you. So this is my plan to talk a bit about the clinical context, a bit about how to prepare specimens, a bit about your naked eye examination, block selection, a little bit about the appendix, a little bit about maintaining links between the macroscopy and the microscopy, and then I'm going to have a section on recent debate, which will raise some further questions and reinforce other ideas. A single slide on frozen sections, and then some take-home messages before the Q&A section. Just to say that I'm sure that many or all of you will be aware of the Royal College of Pathologists website and the fact that there are many data sets there for reporting cancers, as well as, of course, many tissue pathway documents for non-cancer specimens. and the colorectal cancer data set was actually the first one initially created about 1998, I believe. This is the latest version of it, created just under 2 years ago by my 3 friends and colleagues that you can see here. It really is an excellent resource for you all to look at, and some of the diagrams that I'm going to and concepts I'm going to talk about today will be also found within this data set. The data set will contain quite a lot more detail. I've just picked out certain things that I think are particularly useful for discussion. So just quickly, I'm guessing that you might receive a very variable quality of clinical information within your own hospitals. That's certainly the case where I work. We also need to understand the nature of the resection. Often that's self-evident from what we can see, but that's obviously still very important because we need to understand the anatomy. We need to be able to orientate the specimen. Clearly, many of these cases, or almost all of them, will have been resected for adenocarcinoma, but nevertheless, it's important to know, was there a preoperative diagnosis? There might not have been, of course, if the specimen was taken because of an emergency, such as obstruction or perforation, but very often there will be preoperative biopsies. They're particularly useful if, of course, looking at the third bullet point, if neoadjuvant therapy was given, there might be a striking response, there might be no response to neoadjuvant therapy, but if there's a striking response, the preoperative biopsy might be all that you've got to work on in terms of the tumour type, etc. Yes, was neoadjuvant therapy given? We're not always told that, are we? If it was given, what type? And for that, primarily for me working in my hospital, that means was short course radiotherapy given or was long course chemoradiotherapy given. That's quite a useful thing to know. Most of the time, again, in my own experience, if neoadjuvant therapy is given, it is the full long course neoadjuvant chemoradiotherapy. And is there a known other condition, such as a polyposis condition or maybe inflammatory bowel disease? That's also helpful to know. We're lucky to have an electronic patient record in Southampton. We can often look these things up. However, it's always preferable that the surgeon gives you as much information as they can about the patient. And then if there's a specific question, you would hope that they would they want to have it answered. You'd hope that they would actually state that on the form. So preparing specimens. Now, of course, we have to open these specimens. Sometimes they get opened in theatre. Otherwise, we need to open and clean them. We would normally open them along the aspect of the specimen that's opposite where the mesentery is. Now, do you open up to or through the tumour? And there's a point that raises debate amongst different pathologists. I think most people would say it's good to open up to a tumour, but not through it, ideally. This is mainly so that you don't disturb the relationship of the tumour to the wall of the colon or rectum within the area where you're actually opening it, because that might be important, for example, for looking at peritoneal surface involvement. But there might be situations, of course, as someone said, neoadjuvant therapy, that you feel you need to open through the tumour site because otherwise you won't really know where the tumour site was. So there's a degree of flexibility there. I think most people would say, in most cases, I would open up to, but probably not through the tumour. But you can be a little bit more flexible with that after neoadjuvant therapy. Or if it's a small tumour that's only involving maybe the mesenteric aspect of the colon, for example. And of course, thoroughly clean the specimen to remove all the bowel contents. You might be in a situation where fresh tissue sampling is needed. That's not the case most of the time, but if it is, this could be your opportunity. But of course, the specimen will need to be received fresh, so that will have needed some preoperative communication between the operating theatre and your department. And also, it sounds very obvious, isn't it? But make sure the container is large enough. Sometimes we receive specimens that are in containers that are far too small. And that could be because, of course, in theatre at that particular moment, there isn't a specimen that's an appropriate size. But do consider transplanting a specimen into a bigger container if it doesn't seem as though there's enough formalin around. Make sure the specimens are well covered with formalin and not squashed into the container. And how about orientating the specimen? This is really important because this will help to inform how you approach the specimen from then on. On the left-hand side there, we can see a sigmoid colectomy, and this grey area here is the tumour. There may be an area of peritoneal surface involvement that I can show you in the next few slides. The tumour may extend into the mesentery here, but it's uncommon for the tumour to extend to the base of the mesentery, although, of course, a tumour-involved node could do that. Looking at a cross-section of the tumour, you may be looking here at differentiating between maybe a PT3 tumour and a PT4A tumour, looking for peritoneal surface involvement. So that's going to be an important part to sample. You might be looking at tumour extension into the mesentery here as well. But in the anatomy of these specimens is usually relatively straightforward. Looking at an anterior resection specimen here, you can see a side view and a view from behind. You can see the mesorectal excision plane here is in this dark grey colour. Of course, the rectum is divided up into thirds. The upper third is covered on the anterior and lateral surfaces by peritoneum, with the beginning here, the superior aspect of the mesorectal adipose tissue only in the posterior plane. In the mid-rectum, you've got the mesorectal adipose tissue posteriorly and laterally, and then you've got your peritoneal reflection, which I'll show you again in another diagram in the next slide, in this position. And then the lower rectum has no peritoneal covering, so you've only got a mesorectal excision plane. And you can often work out where you are by looking for this inverted V appearance. If you look at the posterior aspect of the specimen, you should be able to identify this free peritoneal surface edge here, and that should help you to work out where you are. And of course, when you cut this transversely, you've got the lumen here. The anterior mesorectal adipose tissue is usually significantly thinner than that laterally or posteriorly. So here I've indicated a posterior tumour, and of course you'll be looking at the distance between the leading edge of the tumour and your mesorectal excision plane. And if there's a tumour-involved lymph node, you look at the distance between the node and the mesorectal excision plane as well. So it's really important to understand this anatomy. Of course, if it has an abdomino-perineal resection, which isn't illustrated here, you'd have additional tissue at the bottom here with the anal canal. And I've got some pictures again from the data set, in fact, in the next few slides to illustrate that for you in a bit more detail. Here we have a right hemicolectomy on the right side, again largely covered by peritoneum, although in fact we've realised that the posterior aspect of the distal cecum and the proximal ascending colon has a variably sized and shaped non-peritonealized surface here, again in grey. And it is possible for this surface to be involved by tumour, particularly tumours that are in the posterior wall of the cecum and proximal ascending colon, or tumours that are circumferential. So this then becomes a little bit like the mesorectal excision plane, although it isn't as well defined. But you can normally identify it because you can see the free edge of the peritoneum in this position as well. And then you can ink that, as has been done in here. This is a very good paper. It's a little older now, by Dr. Luhmann and Professor Neil Shepherd, but still very much worth referring to. It still has some very good pictures, including this one with an inked retroperitoneal surgical margin. So you may well be able to identify that in your right hemicolective specimens. That's really important to be able to orientate these specimens. This is a rather more diagrammatic representation of the anterior and posterior aspects of an anterior section specimen. And of course, the level of the peritoneal reflection is taken as the anterior level of it. So the lowest level here is the anterior wall of the rectum. And then if you look at the right-hand side here, tumours can be described as above the peritoneal reflection if they are within a part of the upper rectum that is mainly covered by peritoneal surface. They may be entirely beneath the peritoneal reflection, in which case there's no peritoneal involvement to be concerned about the possibility of. But you've got the bare area here, or the mesorectal excision plane, that is potentially involved by tumour, or may be involved by tumour, and then you've got tumours that are at or straddling the peritoneal reflection, so they will have a combination of potential peritoneal surface involvement and maybe a distance to the mesorectal excision plane to look at with possible involvement. So these are some pictures from the cancer data set, just to show you here that we are encouraged to examine the quality of the mesorectal excision plane in anterior resection specimens. Here you can see this is peritonealized surface here. This is a non-peritonealized mesorectal excision plane here. So the value of total mesorectal excision, so-called, of removal of all of the tissue around around the rectum here, to find in this shiny plane here during surgery, the mesorectal excision plane is associated with a much lower risk of positivity of this margin and much lower risk of local recurrent adenocarcinoma. This is how it should look. This is a lovely shiny fascia covering the circumferential margin with no defects in it at all. That's called your mesorectal plane. If there are defects within the mesorectal plane, you can see there are some here. Here's your peritoneal reflection here. Here's your anterior peritoneal reflection. There's a defect here. So potentially, if that was where the tumour was, there may be compromise of the surgical margin there. That's your intra-mesorectal plane. So hope that doesn't happen. And you really hope this doesn't happen. In my experience, very rare. You hope that you can't see the muscularis propria by looking at the outside of the specimen, because, of course, your mesorectal excision plane will have been compromised to a much greater degree. So we are encouraged to make a comment on the quality of the mesorectal excision within these cases. I mentioned a few slides ago about abdomino-perineal resections. They used to, a long time ago, look something much more like this, with this so-called wasting in this central picture, with the bottom of the mesorectal excision plane here, shiny surface, and then a much more of a narrowing here with the anal canal beneath the peritoneal reflection, well beneath it, beneath the mesorectal excision plane as well, where the vata veni comes in here and blends with the external anal sphincter. And of course, you can imagine if a tumour is here, there's a much greater chance of involvement of the circumferential margin in this position. So this could be a low rectal tumour or an anal tumour. So now what people will tend to aim for is to take much more tissue within the low rectum and the anal canal area, taking more of the levator muscle here and having what you might call a cylindrical operation, where there's no wasting or narrowing here as you work your way down beneath the level of the mesorectal adipose tissue. So if you have an abdomino-perineal resection, you usually hope that it looks like this, especially if it's been sent as an elate resection, which is an extra levator abdomino-perineal excision. And you certainly hope that you don't see something like this with a very irregular connective tissue, muscle, and adipose tissue on the outer aspect of the low rectum and anal canal. You definitely don't want to be seeing this. So you want to be seeing something like this. They used to look like this, but you hope that you don't see this. Okay, so hopefully we've prepared a specimen and we've orientated it. We've made some assessment of the quality of the surgery. And then how do you take your blocks? When I'm doing this, I always think to myself, well, I need to take blocks that will enable me to fulfill the purpose for which I'm taking them, i.e. the provision of an accurate and succinct histopathology report, which will help to guide patient management. So clearly you want to confirm the tumour type and grade, although most of the time we already know that from biopsies, because biopsies would have already been taken. We'll need to provide a TNM stage, a pathological TNM stage, a PTNM stage, or a YPTNM stage, so-called, if it's taken after neoadjuvant therapy, and then also provide other useful prognostic information from the data set. For example, small vessel and venous invasion, a perineal invasion, whether there are extramural tumor nodules, which I'll mention a bit later as well, what the margin status is. So that could be the circumferential resection margin, or that could be maybe the distal longitudinal margin if the tumor is very close to the distal longitudinal margin, for example. And other findings such as, are there polyps, is there inflammatory bowel disease, things like that. Is there a second adenocarcinoma that hasn't been identified? And so whenever I'm making my description and trying to choose which blocks to select, I always try to think about how they will help me to answer all these questions for the surgeons and the oncologists, and you hope to then facilitate your discussion at your multidisciplinary team meeting when that happens. And also, of course, increasingly nowadays, you may be wanting to provide tissue for other things, such as genomic studies, BRAF, KRAS, NRAS mutation analysis, for example. Okay, so there are some extra naked eye clues. There's another nice diagram from this earlier paper I mentioned to you earlier in this talk. This is another collectivist specimen, and you can see here, this is the anterior surface, and there's a very irregular surface here, serosal puckering. And again, these pictures are from this very good paper, which I'll refer to again soon within this talk. This is another example of serosal puckering. Whenever you see this, I'm highly suspicious that there may be peritoneal surface involvement by the tumor. And of course, that will upstage it potentially, for example, from a PT3 to a PT4A. Very often, the corresponding histology is where there's carcinoma extending to a peritoneal surface, often within a cleft within the mesentery or within the serosal tissue, because often this is where the elastic fibers that are typically present in the subperitoneal area are often absent, a bit like in the pleura, and that's often a very good place to look for peritoneal surface involvement. So you definitely want to sample quite thoroughly areas that look like this within your specimen. And then you can see over here, again, from another very good paper from Professors Traynor and Quirk here, that this is a transverse section of an anterior section specimen where the mesorectal excision plane has been inked black here, and the lumens here, it was virtually a circumferential tumor. But you can see here, these linear foci of tumor, these tongues of tumor, are very, very likely to represent extramural vascular invasion. So do look out for those features like that, and then sample those to see if there is extramural vascular invasion happening. Okay, so if you've identified all those features, how would you try and plan your block taking? Well, most people say that you should only really need to sample your longitudinal margins if they're within 3 centimeters of the tumor. Although I would say, even if the tumor's well clear of the margins, I tend to take one block of distant bowel wall just to look at the background mucosa, and in a right hemicolectomy, I'll tend to take a piece of the terminal ileum and a piece of the distant ascending colon, not because I'm necessarily worried about where the tumor is in relationship to them, but so I can check for anything previously undiagnosed that might be present within the distant bowel. Most of the time there isn't anything, but I think it's still worth doing. And I would suggest at least 4 to 5 blocks of the tumor, particularly focusing on areas, as I've said before, that might represent peritoneal involvement, and also to show the deepest point of invasion through the bowel wall and the proximity to any non-peritonealized margin, particularly the mesorectal excision plane in rectal cancer, and maybe the retroperitoneal margin in right hemicolectomy specimens. Yes, look for those areas that might represent venous invasion and sample those as well. If there are other lesions, sample those, polyps, for example. Look for your highest lymph node. Now, that's not actually an item that's required for TNM staging, but the dataset still recommends that it's worth looking for your highest node, because if that's involved, it probably does suggest a worse prognosis. And then, of course, look for further nodes, and I'll talk a bit more about further nodes in a moment. So this is a diagram that's a little bit like diagrams that you've seen earlier on this talk. Here's a a tumour that's transmural in nature. This could be a rectal cancer, couldn't it? So you've got your mesorectal adipose tissue here, your mesorectal excision plane here. So you're wanting to make sure you have blocks where this distance can be measured, the greatest extent of extramural tumour growth, the proximity to the margin, and also the distance between either an extramural tumour deposit or a tumour-involved lymph node, or even in a vessel, and your mesorectal excision plane. And if you do identify this, if this is the closest approach to the margin is because of one of these features, you should record it and indicate in a comment in your report that actually the primary tumour might be 10 millimeters from the margin, but there is a tumour-involved lymph node or there's an extramural tumour deposit within a millimetre of that margin. Relatively uncommon to find that, but it can happen. Now, I don't know how many of you in your hospitals have access to large blocks and therefore large slides. We don't recommend them for use in routine colorectal cancer resections. They're quite labour intensive for the labs to prepare, but they can be useful in complex cases. We do a reasonable amount of pelvic exenteration surgery here in Southampton. That might be for locally advanced and/or recurrent colorectal cancer, or for other sorts of cancer such as gynecological cancer, sarcomas, and urological tumours. They can be useful for helping to sort out the position of the tumour within a relatively complicated anatomical situation, and they can, in that situation, save quite a lot more small blocks being prepared. So useful in that situation, and quite useful when you come to look at them either on a microscope or in fact on digital pathology. I think large blocks come across very well in a digital pathology setting to try to map out where a tumour is if it's within a complex anatomical situation. Of course, what I would say is if you are going to do large blocks, I would include at least one small block as well, in case other studies are needed, immunochemistry or in particular genomics, so that there's a small block of tumour that's ready for that purpose. Okay, the lymph node search. So the previous version of the college data set suggested that 12 nodes, a median of 12 nodes across your cases was sufficient. In fact, now in the latest version of the data set, that's been increased to 15, but people tend to take that as a minimum rather than a median, even though actually it is supposed to be a median across your cases. Of course, sample the highest node, as I've already said, if you can find it. I don't think there's any substitute for A, not being rushed during this process, we're looking for nodes, B, having a decent knife and good light, although of course you can also feel for the nodes as well. Be careful not to squash small nodes whilst you're doing that. I think if you're struggling to find nodes, something I find very useful is assuming you've done all of your other block taking and you've got the blocks that you need, particularly that relate to the greatest extent of extramural tumour spread and the proximity to margins, for example. If you've got all those blocks and you're happy with that, you can, and you're struggling in particular, you can remove the adipose tissue from the specimen. That does allow, I think, finer and more systematic dissections. I really find that's helpful. Sometimes, despite doing all those things, you don't find as many nodes as you would like, and you can, of course, return to the specimen after further excision. That can sometimes help. The nodes can be firmer. I'd also suggest not putting too many nodes into each cassette, because at the embedding stage, that can be awkward for your biomedical scientists to ensure that all of the small lymph nodes, if you're finding small nodes, are present in the right position in your block. So I wouldn't put too many nodes in your cassette, just use a few more cassettes if you find plenty of nodes. People used to think that, for example, if you had, I don't know, obstructing carcinoma at the splenic flexure with an obstructing dilated colon proximal to that, and the patient has a subtotal colectomy, people would think, oh, I've got to sample all of the nodes from the entire specimen. But actually, you don't really need to do that. You can just sample them from the area that's relevant to the tumour. The chance of a lymph node at the ileocecal valve containing metastatic carcinoma from a tumour that is present in the splenic flexure is very, very low. It's more important to focus your lymph node search within the area relevant to the tumour. I wanted to mention fat clearance. Well, some labs, certainly in the UK, use this routinely, but most don't use it routinely. And generally speaking, the feeling is you will find more lymph nodes, but actually it's uncommon to actually upstage the nodal stage, the TNM stage for nodes of a colorectal cancer doing that. I'm just highlighting one study here. So again, it's a little bit older now, but these people used, and there are different sorts of fat clearance that you can use. These people used alcohol for 24 hours. And you can see here, you've got two groups of patients. On the left, table 1, patients who hadn't undergone neoadjuvant therapy, patients on the right, table 2, who had undergone neoadjuvant therapy. You can see in both cases, you can compare the traditional method with the fat clearance method here and over here. They found many more nodes, you can see, which are a significant number of additional nodes within both of these samples. But in fact, in the patients that hadn't had neoadjuvant therapy, there wasn't a significant increase in the number of positive nodes found. There was actually in this particular study an increase in positive nodes found, but not a huge number, greater, within patients who had neoadjuvant therapy. So it is possible that within selected cases this might be useful. The difficulty is there are potential health and safety issues with having large containers full of that absolute alcohol or other solutions that might contain, for example, glacial acetic acid within your laboratory. So most labs don't do this, although some do. So as I mentioned, tumour deposits. Now, I know these are really a microscopic rather than a macroscopic diagnosis. And of course, in previous versions of TNM, tumour deposits over 3 millimeters across would, in some versions of recent versions of TNM, be counted as a tumour-involved lymph node anyway. But just to tell people what they are, they're essentially foci of tumour separate to the main primary tumour, without any obvious lymph node structure or evidence of vascular or perennial invasion, although they almost certainly would have actually developed through one of those particular routes. And the importance is they seem to impart a prognosis that's worse than for a corresponding lymph node metastasis. So they're important to identify. You'll probably find them during your macroscopic assessment and dissection, and think that they're lymph nodes. It may only be later when you examine them under the microscope you find their tumour deposits, but they're still very important to record. And it's different to tumour budding, of course. I've listed what tumour budding is there. That's a very microscopic assessment that is now mandated in the UK for PT1 colorectal cancers, for example, but this is quite closely linked to worse clinical outcomes. So they are different to tumour deposits. So just a few tips at this stage. Specimen orientation, as I've said, is really important. Make sure you sample the tumour sufficiently with that typical number of blocks I've given there. Only sample the margin to assess the background mucosa and the proximity of the tumour to a margin if you're within 3 centimetres of the margin. And as I've said, even if the tumour is further away than that, you can consider taking samples just to check the background mucosa. Look out for serosal puckering. Look out for macroscopic features suggestive of extramural venous invasion. And if you're also looking for small polyps, and you think you found small polyps, what I often do is put them into a separate cassette, or you might put 2 small polyps into one cassette. And I ask for levels at the time of cut-up, because it's quite often that you then receive a single H&E slide if you don't ask for levels, and you'll wish you had asked for levels to identify what the polyp was. Okay, the appendix then, a couple of words about this. There's another very good data set written slightly longer ago, but still very current, by again, 4 of my friends and colleagues here from the UK. You might receive an appendicectomy or a right hemiclectomy for an appendiceal tumour. Of course, you've got your standard blocks, I'm sure everyone would take normally. If the appendix is normal, should you embed the whole thing? That may be a discussion for another time. But look carefully for signs of neoplasia. You might be thinking more here in terms of maybe a neuroendocrine tumour, but of course you might have a low-grade appendiceal mucinous neoplasm or a goblet cell adenocarcinoma, for example. this is just to say in general about the appendix. If you do take an appendix and not talk about cancer for a moment, but if you do that and the initial sections show just inflammation on the outside, that is a very good reason for embedding the rest of the appendix, even if you haven't to begin with. Normally do the same if there is a tumour present, particularly a low-grade appendiceal mucinous neoplasm, because very often some of the blocks have the lining epithelium denuded from them. And if you're in a situation where you think you might be dealing with a mucocele, it's important to indicate in your report whether there was cirrhosis or mucin, and if there was, sample it thoroughly, because even whether or not there are epithelial cells within that still has an importance for patient management. And just a diagram from the data set to show how you can sample a specimen in this particular situation. Okay, so I think nowadays we are moving into an era where, with good reason, specimen macroscopy and dissection is often undertaken by a range of different staff within our departments, and it could well be that if scientific staff are involved, they may or may not be involved with the histological or microscopic assessment. So it's really important that the macroscopic assessment and the block description is clear. Now, I know that some people say that you shouldn't include a block description in your standard pathology report. Some people say you should have your department SOP that would indicate what blocks you should take and what blocks have been taken. Other people suggest you should have your block description within part of your laboratory information management system, part of your pathology computer, that is visible to pathologists, but is not necessarily present in the actual report. But I think most departments would actually include a succinct block description. So whatever it is, whoever's reporting the case needs to understand where the blocks are taken from clearly. So the colorectal resections, as I've said, they quantify polyp numbers within reason. I've certainly been involved in my career with our clinical genetics service here in Southampton, where I've been asked years later, this patient may have a history of polyposis. Please, can you review the specimen? Of course, the specimen and the slides may be no longer available, and the report might just say there are multiple polyps. One doesn't know what that means. So I think it's useful to give some, obviously you don't want to count individual polyps when there might be tens or hundreds of polyps, but to give some idea of how many polyps there are is actually very useful, because it might well be that your written report in the future is all that there exists in the patient record of approximately how many polyps they had, and therefore something which might help to indicate whether they have a particular sort of polyposis syndrome. Yes, we use a macroscopic proforma in Southampton to help to organise our macroscopic description, and you can certainly do that even if you use a proforma. You can include a comment section if you need to. And we don't photograph every single case, but you should certainly consider it, particularly for things like the more complex procedures, maybe the extralevator, abdomino-perineal excisions, or the pelvic exenteration specimens. Sometimes the surgeons find those very useful. They can often relate them to the CT scan. I've said there a personal micro link is ideal. What I mean there is, even if you, as the reporting pathologist, haven't actually dissected the specimen yourself, it really does help if you've at least seen the specimen with the person who is dissecting it, whether that's one of your trainee medical pathologists or one of your trainee or fully trained scientists. I think it is, wherever possible, a very good thing to actually look at the specimen to begin with. You can always advise the person who's doing the cut-up, and at least you've seen the specimen. Obviously, specimen photography is an alternative to that if it's not possible for you to be there at or before the time of cut-up. And again, if someone, particularly if they're training, and if they're not involved with the reporting of a specimen, please do provide feedback to that person in a constructive way, if there's something that you think that they can do to improve their dissection or block taker strategy in the future. So there was this recent debate. I just wanted to bring this up. A couple of very good papers in Journal of Clinical Pathology just last year. There was a sort of a general paper as you can see at the top there, and then there was a paper particularly relating to the GI tract at the bottom there. I've just taken out some discussion points from there. Some of these will be similar to things I've already mentioned, but I think that's fine because you can reinforce these things. In the GI paper, they suggested, in fact, even if a tumour is over 2 centimetres from a margin, you don't actually need to sample it. The donuts, the little rings of tissue that are removed when an anastomosis is performed. Most departments probably do examine those, but they are a specimen that you can consider not examining if the tumour is well clear of the margins. However, just bear in mind those bullet points there. The tumour might extend in places that are not immediately obvious, such as beneath the mucosa. There might be extramural tumour deposits that we've just spoken about. They may not be directly beneath the epicentre of the tumour. And of course, post-neoadjuvant therapy cases are harder to assess. I'm going to talk about those in a moment. This particular paper emphasised what I've already said, really, about distinguishing between peritonealised and non-peritonealised surfaces. Consider resampling. If you've got a case where tumour is close to a serosa or peritoneal surface, you may need to resample. I've added there also that the additional levels may be helpful if you've got a tumour that's very close to a margin, because that might actually result in upstaging a tumour from a PT3 to a PT4A, and then that might actually trigger a discussion about the patient being considered for chemotherapy at the MDT meeting. And this paper, these authors also felt that fat clearing techniques are of uncertain value, although it is recognised that they are routinely used in some laboratories. I mentioned post-neoadjuvant therapy cases. You may or may not receive these in your own departments. Try and document the size of the tumour bed. That might be quite difficult to judge. It is said that radiotherapy can induce fibrosis within the area of the tumour bed. The process of tumour regression might also induce fibrosis, so it may not be entirely clear what the extent of the original tumour was from macroscopic assessment or even from microscopic assessment. But the suggestion is, if it's a relatively small tumour bed, embed all of it. If it's bigger, then sample it in the way that I've suggested there, but then resample, potentially embed all of it if there's no tumour found in your initial blocks. And some people say to be as thorough as possible, by the way. This isn't macroscopic assessment, but to be as thorough as possible. If all of that shows no tumour, cut some levels on each of those blocks. If that shows no tumour, then it's probably reasonably safe to actually state that the tumour appears to be YPT0 with no residual tumour identified. And if there is residual tumour, you can see there that I've said the deepest invasion is usually beneath the most obvious macroscopic lesion, so that will tend to be the area best to sample if there is macroscopic tumour present, because that will give you the most accurate YPT stage. And this is going back to the Royal College of Pathologists data set. There have been various different ways of scoring regression previously, but the current one that's in the data set is this. It's a 0 to 3 scale where 0 is no tumour, so that would equate to a YPT0 or a tumour regression score, a TRS score of 0. At the other end of the spectrum, no response is TRS3, and then you've got just single cells or occasional groups of cells, cancer cells, and almost complete response is 1, and then anything with a moderate degree of regression is 2. Okay, so near the end of the talk now, briefly talk about frozen sections. These are not that common in my experience in GI pathology, perhaps more common in HPB pathology, hepatobiliary pancreatic pathology, which I also practice. However, when we do get frozen sections, then usually for unexpected findings, for example, a liver nodule or a peritoneal lesion. Just before doing this webinar, I was just looking at the patient's paraffin sections. They'd had frozen sections in exactly this setting, but in fact for pancreatic cancer, and unfortunately they showed tumour, so that might be the case also with a colorectal cancer patient. When you're looking at peritoneal nodules, of course, there may be other reasons for having a nodule. The patient might have had a laparoscopy or previous laparotomy. So you might be looking at post-surgical reaction of fat necrosis, for example. You might be looking at a benign inclusion cyst in the peritoneum. So those are other possibilities. You might be looking at regressed tumour, of course, if someone's had tumour present and then they've had good response to chemotherapy. For liver lesions, you might still have adenocarcinoma. You might have a bile duct hamartoma or a von Marburg complex. They typically contain bile, and they typically have quite a bit of stroma and these geographically so-called arranged and shaped bile ductless structures within them without infiltration at the edge. Or bile duct adenoma, that's usually a rather more closely packed collection of bile ducts, so often with inflammation, often with portal tract structures, but without significant atypia, usually without mitotic figures within them, and with an edge that is smooth, without obvious evidence of direct neoplastic epithelial involvement of the adjacent liver. So, as with any frozen sections, try and give a confident answer if you can, but if you can't, you sometimes have to say, I'm not sure, this is suspicious, I'm going to have to defer to paraffin sections, and then the surgeon will need to combine what you've said with his own or her own degree of or level of clinical suspicion. Okay, so what are my take-home messages then? Well, first of all, as with any specimen, really, it comes up, the preparation is important, the cleaning, the way that you've opened the specimen, the degree of fixation that you give it as well, all of that's very important. Many of you will come from warmer countries, maybe. Certainly here in the UK in the winter, our cut-up room gets very cold. Specimens seem to need longer to fix when the formalin's cold. So there may be geographical variations in the challenges that you face in your own laboratories. And it's so important to be able to relate the naked eye appearances, the macro appearances, to what you see down the microscope, whether that's you directly correlating that, or whether that's correlation with a colleague cutting a specimen up with your guidance and comparing maybe to what you've been shown of the specimen or to specimen photography. Whenever you take blocks, always think about how they're going to help you to complete your data set and to answer the questions that are important to answer for clinical management. Provide a clear block key. Whether or not that is actually part of your final report will depend on your individual department's policy in that way. Often it will be put in your report, in which case it's even more important to make sure it looks clear and doesn't make the macroscopic assessment or description look too cluttered. As I've said, always consider when you take samples how they will help you create your final report. Discuss with the reporting pathologist, because you might be the reporting pathologist if you're not, and you're cutting a specimen for someone who's going to be reporting. Always discuss a specimen if you're uncertain there's something unusual about the specimen or complicated. And just bear in mind that long after the slides and maybe even the blocks have actually been discarded or they're just not available, the written report, your macroscopic assessment and the following microscopic assessment may be the only record of the patient's specimen and their diagnosis in the future, particularly, for example, with things like polyp numbers. So that's the end of my talk. I'm very happy to take questions if there are any questions.
Yes. Thanks a lot, Professor Bateman. I think there are multiple questions, and let me just go back to the PPT slide. Sure. Just a minute. Thank you for a comprehensive talk. You've given us a lot of practical points. Thank you so much. So we'll go on to the questions. I have noted down the questions. There are at least there are some number of questions as well as comments. So let me go through it one by one.
Sure.
Do you normally take CRM in right hemicolectomy? The distance is usually too large. Is it okay just mentioning gross distance? Is that enough?
Yeah, I think that's a very good question, and that you could apply that to an anterior resection or AP resection as well. I think that's very reasonable. When I'm cutting a right hemicolectomy specimen, I'll look at where the tumor is. If it looks as though the tumor is within the size of the tissue you might put into a paraffin, into a cassette, if it's within that distance, to the margin, I will usually sample it. If it's much further away than that, I won't always sample it. So I think there are situations, if you're confident that you're not going to be missing anything microscopically, I think that is reasonable, yes. So I wouldn't always take it, but if I had concern, then I would take it.
Okay, thank you. Something similar, one of the candidates has asked, I was asked to take CRM in a high anterior resection specimen where the CRM was at least 50 millimeters away. I was confused. Would mentioning microscopic distance be enough in such situation?
That's a very good question. Again, a similar question, really. Often people would say, Epson. The only thing I would say is, of course, having spoken about extramural tumor nodules, or maybe very small lymph nodes that could be involved by tumor, or foci vascular invasion, it is theoretically possible that one of those could be present close to your resection margin. In practice, it's unlikely. I have seen people just take one or two blocks to include the mesorectal excision plane, even if they don't think that the tumor is anywhere near it. So that is, if you're asked to do that, or you feel that you might wish to do that, that is, I think, a reasonable strategy. I don't think everyone does that, but that is a reasonable strategy, even though I think your pickup rate for tumor will be low in that situation.
Okay, yeah, sure. Thank you. What's the thing? I mean, this is a question regarding metastatic nodes, and you mentioned about nodes along the specimen as well as a high pedicle specimen of the node. So, what is the significance of metastatic tumor in other nodes, but negative apical node?
Whether or not the high tie node is involved doesn't affect the TNM classification. Some people say, why do you need to take it? Well, the data set suggests to us you should still take it, because if it is involved, it has a slightly worse clinical outcome for the patient. But in fact, in practical terms, if one or more lymph nodes are involved, whether it's the high tie or not the high tie, then the patient will usually be considered for chemotherapy in the post-operative period if they're fit enough. So I think if you can't find it, that's fine. Just try and find enough other lymph nodes. If you can find it and it's involved, it's worse news for the patient, but it probably won't affect their management further, because it's very likely, for example, they'll have other lymph nodes involved.
Yeah, thank you. I think I have a confession to make, in a sense. I do practice GI and gynae path, but we have kind of given up looking for apical nodes. We look for all the nodes, and I think our clinical colleagues are all right with TNM classification. As if you mention it, they're not particularly looking for Duke's staging. But I think that's
right. I think it's advised that you look for it, but in fact, in reality, in a practical setting and MDT meetings, it would be rare to actually for the status of the high tie node to materially affect what happens to the patient later. I think that's a good point.
Yeah. So there are a couple of actually important comments. One of the candidates has mentioned, while you were discussing on fat clearance, there is a comment that there is a delay of coming the slides to you. So that we have to keep in mind if you are actually practicing, your lab is practicing fat clearance techniques for lymph nodes.
Yes, that is true. I suppose it depends on how long you leave the tissues within whatever fat clearing medium. It could delay things by a couple of days. That's true. I suppose going back to a specimen can also delay things as well. So that's a reason why it can do. So I think that's why I think where it is used, most departments don't use it, but I think there could be an argument for using it in particular situations where you've got a difficult case, in which case the MDT are probably going to be happy to wait. But most labs, I think, most of the time, don't really use it.
There is a useful comment while you were discussing about the key or block labels. I think it's one of the candidates has said that it is really very useful. I might add that we do get slides which are patients operate in different hospitals, and I think if it's your case is going to be reviewed by somebody else, the labeling key or the block labels are extremely useful. That's one of the very good comments.
I agree. I do agree. Yeah.
I can see there are a number of questions, but I believe we have time, and I'll just go through one by one. Is there a difference between a CRS score in the patients who have taken only chemotherapy versus patients who have taken chemotherapy and radiation therapy? Will that, or the CRS code labels would be the same? I suppose. Yeah.
Is there a difference? Well, I suppose that might apply to colonic cancer and people who've had just chemotherapy for advanced colonic cancer rather than for colorectal cancer. You still use the same tumor regression score. So I think if you're told that the patient's had neurotherapy, you should try and apply that score using the same principles, is what I would say.
Yeah. Okay. Another question is, should the mesenteric margin always be represented with a colonic wall? The question is, can it be submitted without the wall if the distance is too far from the wall itself?
Yes, it could be. I mean, quite often now, I know the surgeons now, certainly in the UK, for example, for colonic resections, are encouraged to take as much mesentery as they reasonably can to make sure they do actually tie their vascular pedicle off at at a reasonably high level. So that means that very often you'll have a piece of mesentery that might be, I don't know, 80, 90, or 100 millimeters in length. Yes, you definitely won't be able to get all of that into a cassette. So I suppose the importance would mainly be if you found a tumor nodule or a tumor-involved lymph node that was close to the edge of the mesentery, then you should sample it in that situation. I don't routinely sample the edge of the mesentery in cases unless there's a sort of macroscopic lesion to encourage me to do that personally.
Okay, thank you. I might insert one of the questions that bother us sometimes during our colorectal specimen, and it's about the lymph nodes and mesenteric, soft tissue deposits in the fat. So if suppose I have two identifiable nodes which are metastatic, and I have to, in addition to that, I have two separate microscopic soft tissue deposits. Sometimes we face a question, you mentioned those separately as per the guidelines, but do you take it as PT N1B, or it's better to be regarded as N2A? And that's the question. I generally make a comment in the report, total 4, better regarded as N2A for MDT meeting.
Yeah.
Would that be reasonable? Yeah.
Good question. I think probably, obviously if you only see a tumor nodule and you don't see any tumor-involved lymph nodes that you're sure are nodes, you'd call that PM1C. I would personally just count for the N1A, 1B, 2A, 2B categories tumor foci that I was convinced were in lymph nodes at the moment, but then I would make a note of the number of tumor deposits as well separately. So if you had 3 tumor-involved nodes and then 4 tumor deposits, I wouldn't include the tumor deposits within the nodal staging, but I would indicate that they were present because that's still the worst prognostic feature. Although, of course, we would have already got to the stage in terms of management where the patient's going to be considered for chemotherapy. So, in other words, I wouldn't normally include them in the node count.
Okay.
Node count. Although I also alluded to the fact that it wasn't that long ago in previous versions of TNM where they would have been included if they were over 3 millimeters across. So,
Yes.
if you're doing a study where you're looking back retrospectively at cancers removed several years ago with different versions of TNM, actually what was called a lymph node under a different version of TNM, wouldn't necessarily be called a lymph node under TNM8.
Yeah. That's so. Thank you. I relied take the rationale from the TNM5, and that was I was coming from. Anyway, I have multiple questions from the candidates. So maybe I'll just read it out one by one.
Yeah, sure.
Is omental deposits and omental lymph node deposits to be considered the same? If not, then how do you differentiate on microscopy omental deposit from omental lymph node biopsy with extranodal extension for any tumor?
Well, I suppose it's a good question. It's a little bit like trying to determine whether a tumor deposit anywhere else is within a node. If you think you can see a lymph node structure, then you can call it an omental lymph node. But again, in my experience, a lot of the time, you can't see anything. If you can't see a convincing lymph node structure, I think you just have to call it mental tumour deposit, clearly that's going to be much more likely in someone that's already got a PT4A primary tumour with peritoneal surface involvement. So I would apply the same principles as I would to tumour deposits that are closer to the primary tumour.
Okay, right. There's a question regarding what is the grossing protocol for non-cancer bowel resections like IBD?
Okay, well, that's a good question. I would say that what's really important is to understand the context of, say, if you've got a patient who's had a total colectomy for ulcerative colitis, ideally you want to try and find out why that's been removed. Now, in my experience, most of the time it's been removed because someone's got ulcerative colitis that's not responding to medical therapy. It could be that the patient is responding to medical therapy, but they're not coping with the medical therapy. Maybe they're getting bad side effects from steroids and they've resorted to surgery because of that. Or, of course, it could be because they're developing neoplasia. Pre-neoplastic change has been identified within biopsies or within lesions. So that's the first thing to find out, because that will help to inform your strategy. Most of the time, as I say, most of the cases, it'll be because it's ulcerative colitis not responding to medical therapy. So you want to try and confirm the diagnosis, have a careful macroscopic assessment of the specimen and a good description. Does it look like inflammatory bowel disease, what we've got? Does the distribution fit for ulcerative colitis, for example, or would it be more in keeping with Crohn's disease? Is there corrosion involved? All of those things. Are there any focal lesions? And then, assuming you've done all that, I tend to sample in a systematic way, where you might, if for a total colectomy, sample terminal ileum first, and then the ileocecal valve, and then I might sample it maybe 10 centimetre intervals, longitudinal sections from proximal to distal, and then make a note in my block description whether any of the samples, maybe from the proximal colon, were from macroscopically normal bowel and which were from macroscopically abnormal bowel. And I will sample any focal lesions as well. So I would just do it in a systematic way, and bear in mind that you might need to go back. And of course, if you look at the nodes, you wouldn't normally need to sample all the nodes. Often it's very easy to find nodes, isn't it, in IBD, because they're reactive, but you sample a reasonable number. It's not like a cancer case. So I tend to do it systematically, but I think the macroscopic features are even more important, probably.
Okay, yeah, thank you. There's a question regarding if this tumor nodule far from the main tumor without lymphoid tissue but near a vessel, would we call it a tumor deposit or vascular invasion?
Well, if you can see that there is, I suppose you've just got to make a sort of professional judgment there. Sometimes people talk about the orphan artery sign, don't they? We can see an artery, but you can't see a vein. And then there's then from that, there's the inference that you've actually got tumor within a vein that's destroyed and grown out of a vein. So if you think you've got that situation, it may be reasonable to say this is an extramural tumor deposit likely to represent vascular or venous invasion. Sometimes you just can't tell, and then you just have to call it a tumor deposit. So I think you can just make a reasonable attempt to look for features that might make you think that something's in a vessel. Look for smooth muscle, look for the orphan artery sign, look to make sure there isn't evidence of perineal invasion. If none of those things are there, and there's no evidence at all of lymph node structure, you have to call it a tumor deposit. But that's still useful, because that's still a poor prognostic sign.
Okay, right. Well, there's a comment regarding after the Appendix 2 slides, all the slides were not seen, unfortunately. Well, I'm sorry for that, but I think our experience or my screen, what I could see, the slides were moving all right. I have checked with the Giles, but one of the candidate had a problem, so I'm sorry for that.
Yeah,
we'll take
sorry about that.
Yeah,
But
we'll go on to
you
the
should
next
be able to see it on the recording. I know that you're going to do a recording.
Yes,
and that should include all the slides. So if anyone has missed it, I'm sorry, I can't tell that, of course, from where I'm sitting. But you should be able to see any material that you couldn't see on the recording, which should be available fairly soon, I believe.
Yes. So, I mean, for the benefit of all the candidates, the oncology pathologist will have the recording up on the website. We'll take about 2 weeks time, but I think probably even sooner than that, the recordings all will be available for us, all of us to see. The next question is how to differentiate between tumor bud and tumor nodule microscopically.
Microscopically, well, a tumor nodule, we're normally talking about something which is an extramural focus of tumor, so beyond the muscularis propria, so usually a rounded, discontinuous focus of tumor that probably hasn't got a clue to how it actually got there. The tumor bud is a small collection of tumor cells, up to about 4 cells in size, that is present just at the leading edge of the tumor. So that might be within the wall. Obviously, if it's a PT1 tumor, it'll be in the submucosa. It could be beyond the wall. In our data set at the moment, we're just mandated to look for tumor bud counting in PT1 cancers, because that's obviously a poor prognostic sign. And you have to be very careful that there isn't inflammation, particularly acute inflammation, because that can actually cause fragmentation or dissociation of the advancing edge of the tumor. So in summary, the tumor nodule is normally something that you'll see on macroscopic examination. It may not be, but it often is. It's much bigger than a tumor bud. But a tumor bud is right at the advancing edge of the tumor, and it's very much a microscopic only assessment.
Okay. A quick question from one of the candidates. Is there a CRM for tumors and a transverse colon?
Well, I suppose you've got the base of the mesentery present, a little bit like the sigmoid colon, doesn't it? I know you've got this complicated anatomy with the greater omentum as well. So potentially you've got the transverse mesocolon there. Sometimes, of course, that's continuous with the connective tissue that is attached to the anterior aspect of the pancreas. So it's possible in advanced tumours there may be a non-peritoneal surface there, but the anatomy is going to be quite variable. So potentially yes, but in most cases, I suppose, unless you have very advanced tumours, it's less likely to be involved in someone that's had an operation, unless it's a palliative operation.
Okay, yeah. There's one very practical question. So you use any ancillary stains to differentiate between PT2 and PT3 tumors in difficult cases?
Not usually, no. I suppose you could use the Desmond stain to highlight the muscularis propria. I tend not to. Sometimes I'll use a Desmond stain if I've got a difficult early cancer, maybe a PT1 polyp cancer, trying to work out if there is actually submucosal involvement and submucosal invasive adenocarcinoma. But I haven't actually tended to use ancillary stains for PT2 versus PT3. I suggest the most useful thing there is thorough sampling of the tumour and H&E sections. I think is for me more useful.
Okay, right. Sorry. Next, we still have a number of questions. I suppose we are okay for time, so I'll take three or four questions more. What about the patients after chemotherapy and radiotherapy? It's very hard to find lymph nodes. Can you give any practical advice?
Yeah, it can be very difficult. I agree. I suppose what I would try and do, I would try and do all the things that I've said. I think separating the adipose tissue from the rest of the specimen can be particularly helpful in that setting, for sure. You might have to return to the specimen when the tissue is better fixed. Some people say that that's a setting where using fat clearing can be potentially useful, although again, even if it is potentially useful, most labs won't be set up for that. Something I've experimented with occasionally in colorectal cancer, I've used it more in esophagogastric cancer, but another thing you could try is some systematic fat blocking as well. You could block out maybe 10 sections of mesorectal adipose tissue or mesenteric tissue to look for small nodes in that setting as well. So that's another thing you could try. I don't often do it in colorectal cancer, but you could potentially do it if you're struggling. So you could do those things. But I'm the same as anyone else. I've had cases in that situation where I've only been able to find a handful of nodes. Sometimes that does happen. And you have to the surgeons have to understand that will sometimes happen. But so I try and improve my chances with all those other things I've just said.
Sure. And any tip regarding which solution would you want to use? Because that's one of the questions following up later on.
Well, we don't use it. I mean, we had one of our biomedical scientists used to work here, did a project a long time ago looking at the use of fat clearing techniques, and they used that. I think is it called is it GWEF or GEWF? We wrote a paper on it, actually. It was in Journal of Clinical Pathology. That does contain glacial acetic acid and alcohol, I believe. That's quite a toxic substance. We could use 100% alcohol. So those are the sorts of things that you can use. Further fixation, I know that doesn't clear fat, but that is also quite useful and a bit less toxic.
Okay. Should we do tumor budding score in T2 or T3 tumors?
That's a good question. I think it does have prognostic significance within those, but maybe at the moment our data set suggests that we should do it in PT1 cancers. It's not mandated at the moment, so it will be a non-core item for PT2 and PT3 cancers. There are other things that are more established risk factors, even though that might come in the future, but it's not currently mandated.
Okay. What percentage of specimens show microscopic tumor in preoperatively treated by chemotherapy specimens where no tumor is visible microscopically or in imaging?
Well, I can't give you a figure for that off the top of my head. I have seen cases like that. My own anecdotal feeling, not based on any hard data, is that we see that less commonly in colorectal cancer than we do in esophageal cancer. But that might also be because in our country, chemotherapy is given more commonly in esophageal cancer than it is in colorectal cancer. So I would say I've certainly seen cases of colorectal cancer, rectal cancer in particular, where there's been no tumor left. I would say that's relatively unusual. So most of the cases I've seen, there was at least some tumor left, a microscopic foci or moderate response, yeah. But even I think that's still useful because sometimes it can make a tumor operable that would have otherwise been inoperable.
Okay. Right, I think we are doing okay. Maybe allow me for about 3 more questions. Is that all right?
Yes, of course it's all right, yes.
This positive lymph node at or near CRM can influence margin status. However, shelling them out from shredded fat precludes this measurement. Would you recommend the tedium of serially slicing fat at CRM to look for nodes in order to avoid this, even if it means using more cassettes for accidentally bisected lymph nodes?
Yeah, I think in practical terms, I think that's right. That obviously, the more that you dissect through your mesorectal adipose tissue or any other non-peritoneal margin looking for nodes, the more shredded the tissue gets, and the less chance you've got of actually defining any relationship between a tumor-involved node and a non-peritonealized margin. So I think that you're most likely to find a tumor-involved node at a margin during your initial lymph node dissection, really. So by the time you've gone back over the tissue and you've dissected the tissue off the specimen, you're perhaps less likely to, hopefully you would have found a tumor-involved node by then. But as long as you've inked the mesorectal excision plane before you start to do the dissection, I mean, even if you find a node a little bit later, hopefully you'll still see the relationship to the ink. Yeah, so I think that's, yeah, I suppose, yeah, the more finely you dissect the specimen, the less chance there is of actually having the mesorectal excision plane, or however, I don't think you can really avoid that. But if you ink the mesorectal excision plane, it'll give yourself the greatest chance, not just in defining the primary tumor distance to the margin, but also any distance from any involved node.
Sorry, Giles, can you hear me?
Yeah.
Yeah, okay, sorry, because I for a couple of seconds I lost a voice. Okay, so right, well, there's one practical question. How can we tell the difference between adherent omental fat involvement, which will be PT4B, and PT3 disease where fat has crept onto the antimesenteric border? particularly where microscopic was done by another colleague, and so you haven't seen it. So how do you distinguish between
That's very difficult. I know what you mean. That's very difficult because it's hard. It may be impossible to tell, I think, whether you've got fat that's become adherent within an area where there was perhaps serosal involvement, or there might have just been inflammatory involvement of the serosa, and then tumours grown into that, compared to an area where there might well have been true serosal involvement. I think that's a very good point. I think you just have to take a pragmatic approach and have a professional judgment. Because, of course, tissue can be adherent to the outer surface or the outer aspect of the colorectal cancer for reasons other than tumor involvement. You might have inflammation with abscess formation and fibrosis, for example. So I've certainly seen that when someone's removed a piece of abdominal wall in continuity with the tumor. Sometimes the tumor goes into the abdominal wall, sometimes it doesn't, sometimes it's just abscess formation at the growing advancing edge of the tumor. I don't think there's an easy answer to that. But I think I suppose you'd hopefully encourage your colleagues who might be cutting a specimen up to indicate if they thought there was a separate piece of adipose tissue, maybe a piece of omentum adherent to the outer surface of the specimen at the site of the tumor. That would be helpful. If you knew that was the case, you'd want to make sure that that area had been sampled thoroughly. And then I would just look for peritoneal surface involvement within whatever adipose tissue is there, really. I don't think you can do more than that. So it's a good example where having a good link between macro and micro is particularly helpful.
Okay, well, there's a question, how important it is to define the lymph nodes resection as follows. Lymph nodes at the level of the tumor or lymph nodes above or below the level of the tumor?
I wouldn't normally do that. That doesn't really feature in the TNM staging. So I think that just finding all of the nodes you can within the zone of the tumor, within the region of the tumor, is the most important thing. I don't worry about whether they're just above or just below or just proximal or just distal. Actually, this is our practice in our laboratory, but the name is not familiar to me, but probably somebody would have seen our reports. Yes, it's an interesting idea, isn't it? It's not something that I've ever done, though, I have to say.
Yeah, so I think that traditionally we have been doing it because radiation therapists are interested in the metastatic tumors are at the level of the tumor, or as you mentioned about, if you have a splenic flexure tumor, you're not unlikely to find ileocecal metastatic lymph nodes.
Yes.
I mean, that it stemmed from that, but I take the point, and it's probably not important as for of course, not important for TNM staging, but well, that has been our traditional practice, and we have not gone away from that.
Well, of course, there might be things, you might have things you do in your local hospitals that your clinicians are interested in and have asked you to do that you historically do. I don't think there's anything wrong with that at all. If your clinicians have a particular interest in something and they ask you to look out for a particular feature, then there's no harm in doing that at all, I don't think.
Yeah. I'll just maybe take one here. Since cecum is completely peritonealized, CRM in this case is peritonealized? Question mark.
Yeah. So when I was talking about the retroperitoneal margin in right hemicolectomy specimens, it's really the very distal aspect of the cecum, and then the proximal ascending colon. Absolutely, a lot of the cecum doesn't really have a circumferential margin because it is entirely peritonealized. Yeah. So it's only the distal cecum. Exactly, and then the ascending colon.
Okay, right. I think we'll stop at that. But some of the questions are probably you've answered partly or initial phases of our talk. Maybe I'll just ask one question, because recently our clinical colleagues in our hospital are telling us that even if we have a complete pathological response in colorectal carcinoma specimens, the location of acellular mucin is important or finding importance prognostically, whether it is in the location of submucosa or muscularis propria or pericolic or perimuscular adipose tissue. What are your thoughts on that?
That's very interesting. I haven't heard our clinicians mention that, but I can imagine why people might think that was important, because there might be you might feel as though if there was extramural mucin, even if it was acellular, that could suggest that the tumor was a higher stage before the chemotherapy was given. And of course, chemotherapy will be given generally for tumors there would be a more advanced PT stage anyway. So that's not something I've actually had experience of, but I'm interested to hear that actually.
No, I think, Dr. Bateman, this has been a fascinating lecture, and you see that more than 24 questions that I'm struggling to handle and to moderate. But thank you so much for taking your time, and thank you so much for giving your very practical and very comprehensive points on that. I will take this chance to remind all the candidates that there are feedback forms which Royal College will send to you on your email. They are anonymous. Please give your feedback. It will take less than 2 minutes because it will help us form or plan anything further. And I must thank Gail Senrati, who has been backbone of our webinar series, as well as Professor Martha Cohen, who has given us a good guidance how to plan these things. So with that, I'll take leave of all of you, and thank you so much for your patience, and thank you so much for your listening. Thanks all. Thank you so
Thank you
much.
very much. I hope I've answered people's questions as well as I could.
Yes, no, that's splendid. Thank you so much.
Thank you.